The perioperative nurse plays an integral role in the prevention and management of post-operative nausea and vomiting, which I will abbreviate to PONV. PONV can cause both patient distress and dissatisfaction. Therefore, nurses aim to reduce such outcomes by implementing specific strategies. Jokinen et al. 2012 exhibits that statistically the general incidence of PONV is around 30% when no prophylaxis intervention is provided. This can result in increased hospital admission and prolonged patient discharge. With this being said, the perioperative nurse needs to adopt various management strategies in order to reduce and treat PONV. McCracken et al. 2008 discusses such strategies, which include the identification and reduction of risk factors associated with PONV, pharmacological prophylaxis and non-pharmacological prophylaxis, rescue treatment, and patient education. A risk assessment tool is used by the nurse in order to evaluate a patient's chance of developing PONV. Gunn et al. 2014 highlights high risk factors, which are primarily female sex, motion sickness, history of PONV, non-smokers, use of opioids, use of nitrous oxide, and the use of volatile anesthetics. Duration and type of surgery can also be risk factors. When a patient is identified as high risk, the perioperative nurse needs to then provide prophylaxis interventions. Pharmacological prophylaxis involves the nurse administering antiemetic drugs. Chatterjee 2011 explains that such drugs work by targeting 4 key receptors involved in the etiology of vomiting. The nurse can administer antiemetic drugs such as ondansetron and dexamethasone. The purpose is to prescribe them before the onset of nausea and vomiting symptoms, which in turn prevents post-operative occurrence. The nurse may also use non-pharmacological prophylaxis, where an article by Sullivan 2006 discusses that nurses should educate patients to drink clear fluids as little as 2 hours before surgery to ensure adequate hydration. Sullivan also states that P6 acupuncture stimulation can be used as a means of therapeutic intervention. Aromatherapy is another therapeutic intervention used. Not only does the nurse acquire a role in prevention, but also in treating patients already experiencing PONV. McCracken et al. 2008 discusses the management of such. Firstly, the nurse needs to assess the nausea and quantify the severity. If they have not received any prophylactic treatment, then an antiemetic can be administered. If previous antiemetics have been given and failed, then another can be administered of a different class. The nurse may also use combination antiemetic therapy, meaning the combination of 2 antiemetics of different classes are given to the patient. This is said to have improved outcomes due to multiple receptors being acted on and so less chance of PONV. The nurse may also educate patients on the risk of post-discharge nausea and vomiting. In conclusion, early identification of patients with high risk is an effective form of intervention, especially enabling improved health outcomes and increased satisfaction for the post-operative patient.